Today, my guest is Dr. Guy Neff, a medical doctor and director of research for the Florida Digestive Health Specialists. Dr. Neff has served as a primary investigator for numerous clinical trials, many of which have been published in high-impact journals. He is a hepatologist by training. In other words, he is an expert in the liver. And he is a passionate believer in the importance of the gut-liver connection. Within that, he is a passionate advocate for the microbiome, and you'll hear him talk about how he approaches nutrition, gut health within his own companies and his patients, and for himself. He's authored over 150 publications and more than 250 abstracts. His work has been published in top journals, and he's been on the review board for gastroenterology-related clinical papers as well. Really enjoyed this conversation with Guy Neff. We seem to have very similar views on the importance of whole, minimally processed foods and the impact of artificial sweeteners and ultra-processed foods on our health and well-being. He is one of the leading authorities on the impact of these new anti-obesity drugs that you might have heard of, these GLP-1 agonists. And he's conducted clinical trials investigating the effectiveness as well as the safety and tolerability of these drugs in patients who've got non-alcoholic fatty changes to their liver, now referred to as something called MASH. Previously, it was referred to as NASH. One of the other interesting things about Guy Neff is he's an entrepreneur. He started and built this digestive clinic. It's grown extremely quickly. And you'll hear about how he's managed to achieve that. In short, it's about delivering on clinical trials quickly and generating great data for the sponsors of these studies, who are typically biotech companies and pharmaceutical companies. So within this episode, you're going to learn a lot about the gut-liver connection, the importance of leaky gut in the context of the progression of liver disease. You're going to learn more about what's coming. How are these anti-obesity agents going to have an impact on chronic liver disease around the world? Plus, you're going to get some insights into how Dr. Neff manages his company and how he tries to prioritize the health and well-being of his employees, which I just absolutely love. As always, thanks for supporting the podcast. If you've got any questions, please reach out on socials or connect with us on LinkedIn or via email. It must be hard in America. Someone told me something really funny recently, which was, so in America, it's a special thing if beef is grass-fed.
Right.
Whereas in Scotland, all you need to look at on the packet is Scottish. If it says Scottish beef, it's automatically grass-fed. There is no other thing than grass-fed beef in Scotland. Whereas I think in the US, it's a little bit different, isn't it? Some of them can be fed feed and these antibiotics, and it's the quality of food is different.
Terrible.
Yes.
Yeah, it's terrible. We're starting to complement our fatty liver, or our liver clinic. We're starting a metabolic clinic for purposes of longevity. Gut health, neural type things, the parasympathetics and sympathetics, getting all that aligned and corrected. And it's quite an undertaking, but, it's in its infancy, but in America, it's hard to do that. And that's what's interesting enough has changed. The patient population I have has changed from the 90s, where it was people that look like you and me that had body mass indexes of 24 to 26, had this NASH disease state. And today, it's mostly people with body mass indexes of 35 to 40 on up. So,
interesting.
Yeah, it's and a lot of that. We're more challenged with making the diagnosis. People are bigger, biopsies are harder to do. Finding the correct tissue on a biopsy is even challenging. So
interesting. So when patients were coming in the 90s, what was driving their fatty liver disease, and how has that changed over time?
Well, we weren't sure in the 90s exactly what caused it. The belief for us then was that it was a genetic type of issue that we were not aware of. It soon became very clear that processed foods were involved in the 2000s and really became emphatic in the teens, 2015, where we started to see body mass index population issues. And as a result of that, we started to see more the prevalence of fatty liver disease markedly increase. But in the 90s, we weren't sure. We called it cryptogenic cirrhosis or cryptogenic liver disease, meaning something causing something that we weren't aware of what it is. But when we look back at it now, we know it was a genetic piece.
Fascinating. So is it fair to say then that there's two key components to this fatty liver state? One is the genetic predisposition, but the other is this environment. So could you maybe speak to both and what's known? And
that's a great question, and it encompasses the entire disease state. Is that there truly is genetic variants that are starting to come to the table that we can use to identify patients at risk or patients that have advanced liver disease. For instance, the PNP genetic variation polymorphism is what we see in the Hispanic population. And that PNP genetic variation is seen in over half of the folks that live in Mexico. And it hasn't been studied in Central America or South America yet, but we expect it's going to be as prevalent there. What we haven't found really that stands out is the thin person. We call it skinny NASH or skinny MASH. And that's kind of profound because we call them skinny at, I wouldn't call myself skinny yet with a body mass index of 26. I always think of skinny as being a body mass index of 20, but we call skinny NASH somebody that's 26 or below. Yet they still have this aggressive NASH. In the 90s, it was about 1% to 2% of the population, more like 1%. That population still exists. And the problem is for that group is unless they have a really astute, aggressive provider, primary care provider, family practitioner, internist, they may not be identified until the disease has advanced to either pre-cirrhotic or cirrhotic stages. And that's most of the time the case.
Wow.
The bigger patient, the patient with the higher body mass index that we're seeing so much of today, tends for some reason to get into our system a little bit sooner. We're catching people with earlier fibrosis stages that have this metabolic issue. I relate it more to insulin resistance. They've gotten so big that the diabetes has started to develop, and now their GLUT4 receptors are not engaged. Now they've got a mess, and we're trying to band-aid it with liver medicine.
But is there a superior way? And we're now diving straight into the essence of the podcast. Why not? So this concept of band-aid versus addressing the root cause of the disease, maybe we could explore that a little bit further. So starting with MASH, and maybe you can tell the listener a little bit more about what MASH means, and then progress to what are the tools at our disposal and what's maybe really going on in these patients.
Well, MASH, just to keep it simple, and this is a way we talk to many of our patients as well, is it's basically fatty liver disease with inflammation. Now, you have fatty liver disease, and you have two components of it. You have it with inflammation and without inflammation. MASH is the piece that has inflammation, and what that means is the liver disease is going to progress. And end stage for that, a problem is cirrhosis. And we don't want to get to that stage. If we do, we want to get involved and manage the case, because we do have medicines today that can pull people out of cirrhosis. Interesting enough. Now, the previous name to this was called NASH, non-alcoholic steatohepatitis. We call it metabolic associated steatotic liver disease now, or steatotic hepatitis. Hepatitis is a bad term in the sense that it makes everybody think that they have infection. And really what it means is hepa means liver, itis means inflammation. So in 1983, Craig McLean, the chief at Louisville, diagnosed this, coined the phrase non-alcoholic steatohepatitis, NASH, with his OB mice. And what's interesting about it is this plays right into the metabolic piece. He actually, on sidebars, would talk about what was coming in America. He had mentioned in the mid-'80s, he would talk about this obesity epidemic that was coming. He didn't call the diabetes piece, but he did say people are going to get bigger and bigger, and we're going to see more of this. I don't think he projected the numbers that we're seeing today, though. But what he showed in his OB mice, which is a really cute little mouse that he did his work on, he gave them Diet Coca-Cola as their food. They would consume this night and day, and their visceral fat would just take off. They look like penguins, so to speak. They had small legs, but just a big belly. And so that's where we came to the sweetener agents that we came to understand outside of stevia has a association with the visceral fat piece that causes this. But again, getting back to your question, fatty liver with inflammation is what we're worried about.
Got you. And do we know what causes the fatty liver piece? And do we know what causes the inflammation piece in these patients?
That's a great question. That's where we've been stuck is why do some people have fatty liver with inflammation and others do not? I think it's in some of the genetic testing that's starting to hit the market. I think we're going to find some very important information that predisposes people to risk. For instance, we're starting to find out homocysteine related problems for people who had COVID. They had a higher risk of clotting disorder. These are things we haven't been looking at in the liver piece, but it is the $1 million question that we cannot answer right now. Who's going to get into trouble and who's not? And we're going to need to know that, because these medicines that are coming on the market are going to be limited by their cost. And we need to find the people that we can prevent from going on to transplant versus the people that we can go through lifestyle modifications.
Could you tell us a little bit more about what these medications are and how they might represent a step change in the standard of care for these patients?
Well, there's 3 or 4 that are hitting the research late stage development. You've got your beta agonist. That's a very similar medicine to your synthroid-like type agents. And what you see in there is a nice process where inflammation in the liver is decreased. Now, is the liver able to recover once this inflammation has decreased within the liver? It has to do with the ability to decrease the triglycerides, we believe, in the liver. Some of the other medicines that are starting to come into play, and I can send you some of the slides that demonstrate this, but we're starting to see the GLP-1s
Yeah.
Very, very promising in the fact that they cause people to consume less, burn weight, especially when you add glucagon. You have people in what you would probably call the resting metabolic rate. We called it the basal metabolic rate. But so much of this has changed, but the what you see with glucagon being added is that people are burning more energy. It's almost like amlexinol, that type of agent, with a GLP-1, which people are consuming less. But I think that's going to open up the door. We're going to hear more about EBX coming up, especially with the dysbiosis and the SIBO that's being created. We've got to get back to gut health.
Yeah.
And that's a big piece to it. Now, there is a triple therapy coming that I think is really going to change what we're doing. And the reason I say that is the obesity surgery market was very strong up until a couple of years ago for people with body mass indexes, especially 40 and above. But what they're starting to show is a tendency to use these combinations before they look at surgery to see who might respond, as opposed to doing a Roux-en-Y or a band or whatever type of procedure they're looking at. So there's lots of opportunity coming. The medicines work. What I always tell my team is this is a glorious time, because in the 90s, all we had were lifestyle modifications, and lifestyle modifications were cut back on calories, try to eat cleaner. In America, that's almost impossible to do, and to exercise more. Today, we still use that. We still say we actually coach people today better on exercise. We talk to people about seed oil diets, getting toxins, chemicals out of your diet, potentially probiotics, etc. So there's a lot more we do today than we did in the 90s. But the neat part of it is these medicines, especially these combinations. There's a couple companies that have medicines that we've studied in patients with cirrhosis that look very promising. We're actually able to pull people out of stage 4, out of cirrhosis, back to stage 2 and 3.
It's amazing.
Yeah. And the neat part of that is now these medicines that we're giving them really work. You're not dealing with a fibrosis type organ. Now you've got the fibrosis starting to melt, and these patients are really responding nicely. It's a great time.
Can I just ask you a little bit about the GLPs and the combination therapies? So how are the GLPs benefiting the patients with liver disease? Is it they're just sort of pushing them to consume less calories? Or is there maybe something else going on in the mechanism of action as well that's beneficial?
That's a great point. This is, especially in the American population, we're seeing people consume less. They have satiety sooner. And we're seeing with the combinations, with the GIP versus the glucagon, we're seeing more burn. So you have less calories coming in and more burn. What we don't know and what we haven't studied is, are we burning subcutaneous fat or visceral fat? So we're adding a DEXA scan here, not for bones necessarily. Obviously, yes, we're going to keep an eye on bones. But I want to know what body compartments we're doing, what we're changing with our body compartment. That's a big deal. But that's the million. You're asking great questions. This is a question we don't really have a clean answer. I remember when we first worked with semaglutide 10 years ago. I mean, semaglutide's been studied a long time. And the first trial we had the most patients in the trial. We had 6. Yeah, I think it was a trial that had like 50 patients, and about 150 sites were in the study. So we had 6. 5 of them withdrew from the trial. they somehow collected the data for the few that stayed in the trial, but the early terms was enormous.
Wow.
And it was because of the loose stools. And we haven't really advanced that much until recently. The Italians showed us that probiotics make a big difference when you start these GLPs. So we've started to look at, and we're trying to encourage the sponsors to get patients on probiotics before we start the GLP-1. For some reason, it puts these folks on fire. Now you're going to hear a lot of folks talk about, well, we have constipation with it. Well, you're going to have one or the other is what I would say. So
interesting. And how transformative do you think the GLPs are going to be if we kind of fast forward 5 years from now? How ubiquitous do you think they're going to be used? And is it just MASH, or could it be lots of other things? You know, what's your sense as someone who's prescribing these to patients?
Well, there was data, and I don't know how accurate it is, so I hate to say, but I've heard it a couple times now, so maybe there is some relevance to it. But it was said that 50% of American adults in America have tried a GLP at some time over the last 5 years.
Wow.
So I think they're going to be everywhere. I think we're going to be using them in recovery. I think you're seeing in addiction medicine, you're seeing memory-related issues, Alzheimer's, neurological related issues. You're starting to see we have an alcohol addiction. We have 2 trials now with those. And it's interesting how quick it works. So
really?
Yeah, we're going to see GLP-1s with something, I think, as the backbone. And it looks like after looking at the semaglutide data that just came out from Novo that was published last month, very promising data. And we're going to probably be seeing that drug start hitting the market in 26. And if the price point is okay and challenging for the market, that could be the start of where we're going to see the backbone of GLP-1s. You start with this and then you add something. So,
wow,
it looks promising.
Wow. Is the Novo product, is that one that's orally administered, or are they still subcut?
It's the injection. Yeah.
Still injection.
Yeah,
okay.
We're still a little ways away from the pill, but
it's still, it's because I think when I was at medical school, there wasn't any talk of GLP. It's come on the scene and it's transforming. Yeah. So maybe you could tell us a little bit more then about your background as a physician, but also I think as a business person, because you know, running a successful clinic. So maybe you can tell us a little bit more about how all of that happened and your interest in
that's. I'll try to keep it short, but I went to college in Texas. I was all set to go to the NBA, so I thought. So I went to college to play basketball, and after my first practice with being the shortest guy on the team, and a pretty good college team, but being the worst guy on the team, I realized I better start hitting the books. So I did that, and I went off to Ohio, Northeast Ohio College of Medicine, where I did my medical school, then internal medicine, then I was a chief resident, and then went off to LSU to do my gastroenterology training. And from there, I wasn't sure what to do in the sense I was basically following my wife around, who was going to do oculoplastics at the University of Miami. So I went to Miami and did an advanced year of endoscopy, then a year of hepatology, then a year of transplant. So I worked in academia for about 20 to 25 years on the transplant side of liver disease. And when I left, I wasn't sure really where to go as far as I knew I wanted to get into private practice liver disease and wanted to make an impact in the community in that regards. But before I did that, I had to resolve a restrictive covenant. And that was where I went to work for AbbVie. I was their medical director. I had a team in Asia, one in the US, one in Europe. So that meant every day I had, as you know very well, I had 6 a.m. calls, 12 calls, and then 6 at night. It was a great experience because what I did is I traveled around the world in visiting my team, but making sure, because we were in charge of getting the Hep C drugs launched by CuraPac and the drugs now that are on the market. Because prior to that, the medicines that we had for Hep C were about 30% effective. Now they're obviously very robust. And so that was kind of the charge that I had, and I spent a great deal of time doing that. But I also, when I would travel, I would visit research centers. And what I learned is that sites that were failing or were closing or stagnant would tell you everything of what not to do. So I learned a lot in terms of strategic development on what not to do, not to repeat history. The folks that had it figured out, and there were very few of them, would not talk. And what I learned too in that, it's interesting because you see about 80 to 90%, and this is the data that's out there, 80 to 90% of these centers struggle, and many of them close by 5 years. So if you can hit that 5-year mark and you're succeeding, you've got something. And for us, from there I went to start Covenant Metabolic Specialists. And what was good for us in this setting is that we're opening up a liver clinic on the west coast of Florida, the idea being that we would help providers take care of liver diseases they were struggling with. And it ended up this mass of fatty liver patients are coming our way that, we have over 100 referrals a month that come in, and about 30 to 40 of them per month need help in terms of getting into a research trial, because that's really essentially the best option for these patients. We know if they get into a research trial, the medicines that we're seeing now, the combinations with the GLPs, are effective in over 60% to 90% of the time. You know who's on drugs, so to speak. So really, essentially what's happened over the last 5 years is we've created an entity that's the busiest fatty liver disease program in the world right now. And that comes with 80 hours of work a week and all the overhead, not necessarily overhead issues, but HR issues, as you can imagine.
Oh yeah, absolutely. Did you take on any capital to start your clinic, or did you self-finance?
We got a loan, and I unloaded my retirement plan. So I'm doing my retirement plan right now.
Good for you.
So, but yeah, it was pretty crazy because we went through COVID. We went through the first 6 months of it was COVID, and they were telling everybody to close down clinics, and we kept ours open, and companies wanted to keep moving, and so sponsors wanted to keep moving, so we did that and got through it, and it's worked. So
that's awesome.
But it's not for the faint of heart. Creating one of these is what I always tell people. And we now have a consulting company that goes out and helps sites try to avoid the pitfalls that are forthcoming, is what I always call them.
And maybe just for the listener to kind of understand, the sponsor is the company that's developing the investigational medicinal product, and they've got, overall responsibility for the safety of the drug, the conduct of the study, and so on and so forth. But they rely on clinics and what you call trial sites to match patients who meet the predefined criteria with the drug. So actually, trial sites are a completely fundamental facet of clinical trial. And invariably, I'm probably less experienced than you in this, of course, but some sites do better than others. Some sites have more patients coming through. Some patients have less what you call screening failures than others. Some sites have less documentation issues than others. And as a sponsor, someone who's like, running the company, you want to pick your best sites. And it's really, really hard to find great sites. That's what I'll say. And it sounds like that's your unique selling proposition for companies, is your site performs very well. And I'm not going to ask you to go into any of your know-how or secret sauce, but maybe you could talk about, the principles associated with this and what your role has been in building the business, because I think that's always interesting to hear about.
Well, it's an interesting question because it really goes back to my experience with research since the late 80s and 90s and where we are today. I'm sure you're aware of, with the fatty liver disease state, that many trials suffer a very high screen fail rate.
Yeah.
And what has happened is there's a bit of a process that really needs to be remedied on who is getting screened. We have a trial, for instance, right now where there's over 300 sites open, and we have over 50% of the patients that are randomized. Our screen fail rate is 50%, but the trial screen fail rate is 95%. So if you pull out our RANs, that screen fail rate goes up to 99%.
Really?
And the reason I bring this up is we have a pretty painful process that we consider our norm. In the 80s and 90s, when you screened a patient for a clinical trial, it was a 2-day, sometimes a week, that separated the two visits. The first visit was to bring a patient in and get them comfortable with what you were doing, what research is. Get rid of that guinea pig connotation that they're carrying around. Get rid of the, hey, I have liver disease, people think I'm an alcoholic. Get rid of all those questions and educate these patients. And we spend about 2 hours with these folks doing that. Sometimes it's longer than that even. We do testing to make sure, we review their medical records. We go through the whole gamut to make sure this is somebody that fits. And then we present the ICF and they take it home. Take it home and read. And they get people coming out of the woodwork. Oh, I wouldn't do a clinical research trial or this and that. Sometimes I have to get on the phone and talk to them about really what's going on in life. That, hey, you're pre-cirrhotic or you're cirrhotic, and your brother that you haven't talked to for 20 years who's telling you not to do this, there may be a reason behind that. Let's see what your life insurance policy looks like. But, I'm being sarcastic, obviously.
Yeah.
But we do have a very serious heart-to-heart talk. And what that does is that gets the patient in complete agreement and complete alignment, and gets them committed to what the clinical trial is. And that's one of the big pieces of our success. I don't want to spend 30 minutes on telling you every step of the way we go, but it's pretty simple. We go back to what we did in the 90s when we had Hep C trials, immune suppression, cancer trials. These were trials that these drugs were pretty toxic. You'd put somebody on an interferon therapy for hepatitis C, and they were going to have the flu for a year.
Oh, wow.
And they were going to be miserable. So we would have that discussion. Well, we're putting people on NASH or MASH medicines now, and they're going to have some kind of a GI disturbance. They're going to need, it's either nausea and vomiting, or feel terrible because they're not eating, or the loose stool issues coming. So we spend a lot of time explaining that. So our dropout rate is better than most. It's at the lower side, and our screen fail rate is about half of what you see. We're trying to get that down to 25%. Most sites are trying to get it less than 90. But what they do is they get paid for screens.
Yeah.
And that's where, to me, I find it very tough for sponsors, because you as a sponsor, you're taking it on the chin with some of these trials. Not only is there a time issue, because screen fails make the trial stay open longer, so the burn rate for a clinical trial goes up.
Yeah.
There's no win in screening the wrong patient. So
completely agree. So that was really, really interesting. Thank you for that. Could we maybe just shift gears a little bit and talk about the gut-liver connection? And maybe you could take us back to when you first started practicing. Was the gut mentioned as an important... the gut health, was this important, or,
I laugh because it's not. Yeah. And, I overuse this statement, but it is profoundly true, is that there was a mic drop 2,500 years ago by Hippocrates when he said it all starts with the gut. Yeah. Well, guess what? It does. I mean, I would love to have met the guy just to hear that.
Yeah, me too.
That lecture, why it starts with the gut. Because how could you be so right so long ago, and yet we're ignoring it? It's intimidating, though. I will say I remember in medical school, we would talk about a few of the gut bacteria, and I was like, holy cow, I can't pronounce the name. We've got to give it a nickname or something like that, how am I going to remember it? But so much of it is starting to evolve, and I've actually taken the dive and getting and starting the fellowship training for A4M, which is the functional medicine pathway in America. We're adding, as I mentioned too earlier, clinic process here for metabolic health. And a part of that is gut health. And you guys are lining up to be a huge part of that. The gut health, I think there's a lot we do not know about. I just came from EASL, the study for liver disease of the European Society, and there were a few comments about the microbiome. But, if we're Band-Aid, and I call it a Band-Aid, when we fix the liver issue and we don't fix the gut, it's going to come back.
Yeah.
And if you fix the liver and you don't fix the lifestyle issue, and I'm not talking about walking more, getting on a bike, or running or lifting weights. I'm talking about getting chemicals out of your food, seed oils, getting healthy, eating healthy. It's all an evolution for patients to go through this, and we're not there yet. I remember when we opened up, this is terrible, but I'll tell it about myself. But when we opened up our clinic 6 years ago here, now it's a little bit longer than that ago, but we have a snack basket for patients because they come in NPO, and the first snack basket was created by our HR person. Well, she put in everything she liked. So we had Oreos, we had Chips Ahoy, we had Fritos, and I had just spent 10 minutes telling a patient what not to eat. And I turn around and she's walking in the door with a bag of Fritos for the patient. I'm like, oh, good Lord. I need some help. So we're getting there, but painfully slow is what I would say.
Mm-hmm. And are you doing any gut health testing, gut microbiome analysis in your clinical practice, or are you still waiting for more technology and validated approaches to become available?
We are on the metabolic side, and that's a great question because it's a bit of a slippery slope for us, because one of the first things we look at is genetic testing. I want to know where the SNPs are. I want to know, because I think if we're going to go after these disease states that are associating and combining and creating the metabolic piece, we have to know what the root cause is. And it's kind of like trying to treat somebody with a COVID clot and you haven't dealt with the homocysteine issue. It's elevated. You're gonna continue to get into trouble. The complexity of the microbiota, the epigenetics, the toxins in the environment. So yes, we're starting to order a lab panel, a simple lab panel, to look at the gut stability.
Yeah.
But I'm not sure where that's going to lead us, because it costs a lot of money. I can tell you in the NASH MASH world, whenever I mention HBR or HRV or sleep quality, things like that, and I start talking about zonulins, boy, people start hitting their heads on the table.
It's amazing, isn't it?
It's really discomforting to me, because this is the key, is the gut health piece. And until we have that figured out and straightened out, we're going to keep running around in circles like we're doing right now, is the way I feel about liver disease.
Your comment about the sleep quality, HRV, maybe zonulins a little bit further afield for, just your attuned listener or your medical doctor. But why do you think it is that there's, and I saw the Whoop on your wrist, by the way, I'm also a Whoop user. Yeah, me too. I think, but a big fan. Why do you think there's such resistance to this quite basic concept, which is sleep is important, and the higher quality your sleep, the better? Like, it just seems quite fundamental to the whole thing, doesn't it? We spend 8 or 9 hours every day doing it. So
I think it, maybe it may come across a bit rough, but I think it becomes ignorance is bliss. The less you know about something, the more you're afraid of it. We put Whoops on all of our employees, and it was like an earthquake hit west coast of Florida when I offered it to everybody. I said, hey, we're starting an exercise initiative. I put gyms in all of our offices with a waiver. So if any of the listeners are like, oh, that's pretty bold, you're going to get sued by somebody that falls off a bike or the treadmill. No, we have waivers going. We have a exercise person teaching people how to use things correctly. But when we started this Whoop thing, I was just basically looking at who would do it. And then let's look at HRV. Let's look at deep sleep and see what it does over the next 6 to 12 months with an exercise initiative. So, because I have about anywhere from 15 to 25 college kids, I call them my kids, that are trying to get into medical school. So, and no one does this on the west coast of Florida. So it's kind of like you and I talking about stray cats, how my daughter collects cats. She calls it fostering. I'm like, no, that's not foster. That's called full-blown adoption. But the point of it is these kids all need projects. And what's funny about it now, 6 months later, after putting Whoops on everybody, they're all talking about it. all the time. How was your deep sleep? What's your
Interesting,
HRV doing? It has totally transformed our office.
Wow.
Now I did the same thing with the gym. And I heard lots of complaints. Oh, I've always been called fat my whole life, and now I'm going to get it at work. And I'm like, oh my gosh, that's not why we're doing this. And what I did, one of the things I did, I thought that was clever. It just came to me driving a car one day, is put people in teams. And 90% of the folks, that was brilliant. The 10% that, I don't get along with that person, I'm not going to. Well, I'm like, well, no, you have to get along with them because you work with them. From 8 to 5, we get you, and we're going to do this. So the next thing we're doing, and this will be interesting, is we're going to start these events on Friday afternoons. When your productivity of your team starts to go down, it's Friday afternoon or right before a holiday. So we're putting grills out on our decks, and we're going to start cooking. And we're going to teach people what grass-fed beef tastes like. In America, that's a big deal. That'll be interesting. Stay tuned for the amount of complaints that I'm going to get about a free burger in 2 or 3 hours off of work. So it's interesting.
Wow.
The
that is really
that, we're trying to change people's comfort levels to a healthy setting. And it's unbelievable. We didn't even talk about microplastics and the Starbucks issue where you load up a hot cup of coffee and you're just swallowing nothing but microplastics. So we have mold-free, healthy coffee at work. And I had people say, well, I don't like the taste of that. And I'm thinking, so you want coffee that has mold in it and you're ready to ingest that versus the one that doesn't. And all you got to do is turn the dial to make it more stronger or do what you want.
Yep. So we're very similar in many respects. So we've not gone as far as installing gyms in offices, but that would be a real ambition of mine. So if we're successful in the future and we do that NASDAQ IPO, watch this space. We do offer kombucha. We do offer fresh fruit and
awesome.
Vegetables. We do offer fresh pressed green juice, the lean stuff, and it's really funny. It's super, super funny because the best green juice for you is the one that tastes the worst. Okay, that's just that's just the principle. You just need to understand that. So sometimes we had these variety packs arriving.
Oh my gosh.
And everybody was ranting and raving. James, these new ones, these bright orange, bright red smoothies are amazing.
Oh, God.
And I was like, oh, no, we're not offering those. We have to drink the green ones. But basically, when we started, nobody was drinking them. Nobody but me. But then over time, what I noticed was that people started to develop a habit. They started to enjoy the taste of the lean greens, which is the one that's packed full of the things you need. And then over time, it becomes like brushing your teeth, a habit. You feel good. Yeah. It's a healthy thing. So I think you just need to overcome the resistance to change. And I love the idea of a company Whoop. I think that's a great idea. But I can also completely understand why people go, oh, you're invading my privacy. And, this is a violation. I don't want some things on my wrist. Yeah, I get it.
And that's what I said to one of them during our group call. We have about 80 employees, and we're opening up, like I said, a consulting company. So I'm trying to get this plan in place. So when we open up the consulting company or the CRO, we're going to do all this. But I just came on and I sarcastically said, guys, I don't care how much deep sleep you get. I do care. I really do. If you're not getting deep sleep, we want to help you. But don't think that we're recording it like the government. And what's funny, you mentioned fruit. So I have 2 rules. One is we have to sing happy birthday to everybody on their birthdays. And we do that. And it's amazing because every year there's somebody that's crying. And that crying is because no one's ever done it for them.
Oh, wow.
And that's a transformative moment for that person. It's a pretty neat moment because they become a long-term employee with us for the most part. The other thing is we make sure we do something on the holiday and everybody goes to it. But for the birthday, we got rid of birthday cakes, and we had the best cake baker in America about 2 blocks away. And he'd make these things, and it was like, oh, good, and they'd bring you a piece. I'm like, nothing was healthy about it. And so we moved to fruit.
I love that.
And that was the second earthquake. Oh my God, he's making us eat fruit. And you know what's funny about it is the first time we did the fruit, it was all gone. Everybody ate it.
I believe it. I really believe that.
I was so
it does
happy.
go.
I was so happy because, honestly, in Florida, we have fruit flies, and they're the hardest things to get rid of. So I thought, I'm going to get one of these disgruntled employees that's going to leave the fruit hanging out all weekend. I was planning on coming in over the weekend to make sure it wasn't sitting in the trash. Because we've had that too, where we tried that 5-6 years ago. But society's getting, I think, closer and closer to accepting some of this stuff.
I think you're right.
And,
I agree.
We just have to, at least what we see is we have to force it on. Like we're even, some of our IT team, we're putting on the blue blockers, the glasses. And at first not everybody wants them. Everybody's laughing at, those guys look like they're in the Invincible movie or the, what's the movie with Despicable Me, where the agents are wearing these blue blocker glasses. They didn't know what they were wearing, but now everybody wants them.
Absolutely. Yeah, I Whoop do a good blue light blocking glass, by the way. I don't know if you've got one, but I've got a pair. Yeah, Whoop do some nice accessories.
That's great.
Blue light blocking glasses, and they do a great sleeping mask as well, which I carry on my travels.
No kidding.
Yeah, really good, really, really good quality. And I know they just brought out the version 5 of the band. Whoop should sponsor this podcast. So I'm going to write.
They should. And we should come back on after we have our 12 months or 6 months of data and just say, look, folks.
Yeah.
This little device that, I think it's about $150 a year per employee. It's a business expense, but man, it's transformative now. We have everybody wearing them, and they're still talking to each other about it.
I love that. That's
cool.
Amazing. Good to you. So what's the vision then for your business looking forwards then? You talked about the metabolic side, which I think is super interesting. Where do you hope to be in a few years, 5 years? How does all of this fit together and scale into the future for the benefit of patients?
Well, I think we're now trying to pivot to a metabolic clinic that gets more into the functional medicine realm.
Yeah.
Where we can actually affect lifestyle, because lifestyle is not going to change. And what we know is that if you lose 10% of your body fat, subcutaneous fat, and it hasn't been studied on visceral fat, which is what we're looking at right now, but if you can lose that, and we're seeing that with GLPs, we're seeing that with the combos, that there's no rebound on the disease state. And you see the NASH or MASH go away. You start to see the fibrosis components resolve. So our focus opening up a clinic, we call it ITEA. I know I'm not saying that correctly, but it's the Greek word for root. So we're looking for the root cause. We're getting into genetic testing that, I don't know if I can say it, but the intellects or the strategene, looking at their genetic testing to tell us what's wrong with these folks. Because it's transformed recently over the last couple of years. So from there, we put patients into a pretty, it's about a 3-4 hour visit because we want to look at their VO2. So we're trying to understand the mitochondria health. And the benefit of being an employee here, and I'm not, we're pretty full, so I'm not advertising for employees, but the benefit is the employees get all this too, which is
Love
transformative.
It's amazing.
Because people do not do that. And I think the way I see it is if we have a healthy, happy employee group, we're going to spend less time onboarding.
100%.
We're going to spend less time, releasing disgruntled employees, those types of things. At least I hope. I don't know. We'll see if I'm right soon.
I think you're right. I think you're absolutely right. It's the future. It's the future. And I'm inspired by the vision that you have for the functional medicine side of things, because one of the things I often reflect on, if I think back to my time at medical school, and the purpose of medical school, is to train the next wave of clinicians who are going to have an impact on patients. Of course, recall is always really poor, but I honestly cannot recall having any teaching on this is what good nutrition looks like. These are the fundamental pillars of health: sleep, exercise, diet, community, sense of purpose, keeping stress low, drinking very minimal alcohol. We just weren't really taught about any of that. It was always about, well, this is the pathophysiology of disease Y, and this is the best medicine that we have available at the moment. This is the best surgical procedure that we have at the moment. That we never had any teaching on what is the root cause. And what's really interesting is the functional medicine community have for decades been talking about the root cause and trying to figure that out rather than the pharmaceutical. So has this been a bit of an evolution for you then? You started off in the kind of academic, medical, high profile publications, pioneering surgical procedures, clinical trials. I know you're involved in the rifaximin work, so I did a bit of digging. Has this been a bit of a personal, professional evolution for you? Because you're now going back almost to some fundamental teaching in the functional medicine side.
Well, I'm kind of reliving a little bit with PTSD, because my NIH work was in testosterone for sarcopenia going into transplant. So when people are dying, they shed muscle. They go through massive sarcopenia, and then we transplant them. Then they can't walk for 6 months. Mm-hmm. And when you go back to the true reason for transplant in the late 70s and 80s, when it was first starting, was to get people back into the workforce. And I thought, we've got to do better than that. So I got into testosterone in the 90s. But now they're talking about testosterone in women at these functional medicine meetings, and they're acting like, they're going to get blown up or car bombed. And I'm thinking, well, try this in the 90s with a bunch, presenting. And I would give grand rounds, at a different place every week, because it was the transplant community always wanted to hear what we were doing. How were we getting people to walk sooner? And it was always criticized.
Really?
So now I go to these functional medicine meetings, and these people are brave. They're really standing up. They're making a difference. And this is what it's all about: fixing the gut health, and then finding out what not just SNP, I shouldn't say, what 500 SNPs your patient has, and what can you fix, what you can't fix. Let's find a way to help them. That's what for me, it's been a complete eye-opener going to a functional medicine meeting. And what I always say is, you see the beautiful people. I say that a bit sarcastically, but everybody's in shape. You don't go there and find patients for my clinical trials. I go to the AASLD, and half the people there need a fiber scan. And what I mean is they're carrying a body mass index over 30, 35 and above. Yet they're telling people, hey, quit eating this, start exercising more. Don't do as I do, but you need to do this or you're going to die. So you bring up
so interesting.
I think a big point about functional medicine, and hopefully the wave is coming.
Yeah.
And it has many more coming, regenerative agriculture. Hopefully, more of us get into that. Because
it's the only way to know.
It's hard because I'm tired of eating at the same restaurants. I'm going to continue to do it. I'm going to continue to support the 3 seed oil free restaurants that we have in the Sarasota Bradenton area, but we need more.
Yeah, we do. I think, but the good thing is people like us are talking about it. There's a growing acceptance and growing awareness about the importance of clean eating and not having seed oils and minimizing your sugar. This processed foods pandemic that we have, I think is starting to change. I know that some members of the new administration are quite firmly against it, which has to be a good thing. Well, maybe we shouldn't go down that road on this podcast. Probably, yeah.
I think you can, but I think it's still too early.
Yeah.
But the chemical thing for me is mind blowing. The forever chemicals. If you haven't watched Dark Waters,
I haven't. But thank you for that.
You got to watch Dark Waters. You've got to understand about.
Is it going to scare me? It's going to scare me, isn't it?
Oh, it's for and I was at the University of Cincinnati when this was going on, and what DuPont got away with is crazy, and we're still dealing with it. For you to open up a regenerative agriculture farm in Florida, you have to remove all the dirt and bring in clean dirt that you presume is clean. That's not full of glyphosate or atrazine.
Wow.
Or the 5 other chemicals that they're using, plastics that are loaded in soil as well. So yeah, I'm glad it's being addressed. Because it's really a serious issue when we have patient after patient coming in that are pre-cirrhotic or cirrhotic and have no symptoms. That's the problem with fatty liver disease is you're not going to have symptoms until it's too late. And when it's too late, that means that you're heading for the transplant population. And remember, transplant's not a walk in the park. The 5-year survival at most centers is 50 to 60%, 5-year survival. So think about that. For every 10 people that get a transplant, only 5 of them are alive at 5 years. And the hell that those poor patients go through to get to that 5-year mark is profound.
So should we all be getting routine blood work for our liver function? Should we all be... Is there any non-invasive testing we should all be doing on our liver? Is it cheap enough? Is it available enough? What do you recommend for people?
That's a great question. I mean, look at your liver enzymes, your AST and ALT. We call them transaminases. And don't go by the normal that it states on the labs. If you're above 30, you probably should be looking at some type of fibrosis testing. And you can do that very simply like a FIB4 or some type of non-invasive testing. And if you're really worried about it, we do fiber scans. And FibroScan is a great way, and there are various makers of FibroScan machinery. And that will get you into the basics of what you need to know. And if any of those numbers are elevated, you need to start being proactive. Remember, out of 100 fiber scans that we're going to do, probably 50 or 60 of them are going to be metabolic related liver diseases. And I'm talking about America. We're going to see about 10 to 15, maybe 20% of them will be normal. That's all. When I started this in the 90s, we didn't have fiber scans, but we were looking at liver enzymes and some fibrosis testing then, some of the serial markers we would look at. It was flipped. It was about 80% of people were normal 20% had the fatty liver disease issues. Today, it's complete flip.
Interesting.
So if you have a body mass index that's elevated, if you have a family history of liver disease, and you notice I didn't keep talking about alcohol. In the 90s, we said no alcohol. The FDA and all the clinical trials now is allowing men to have 3 drinks per day and women to have 2 drinks. And a drink is considered an 8-ounce beverage or a shot of liquor.
Every day.
Every day. I know. I wouldn't get to work on Mondays if I did that on the weekend. But nonetheless, they're not necessarily looking at it as a social component. I still convey to patients, I say that the best thing is we need to get this liver healthy. The best thing is to reframe as much as possible.
Abstinence. Yeah.
I get your birthdays and holidays, but that doesn't mean you binge drink either. So in the challenge of it is you have to explain this to people. Because they walk out of there, they read the ICF, the consent form that we give them for a trial, and it says, yeah, you can have 3 drinks a day. Well, they take it to heart.
Yeah. Yeah, that's really interesting. So I just want to talk a little bit about alcohol and then we can move to wrap up. So, as an expert in all things liver, what is your recommendation then for someone that doesn't have sort of pre-existing liver disease in terms of quantity, frequency? Is there some evidence that says, just a little bit of alcohol, maybe not such a bad thing? These blue zones in the Mediterranean area are maybe having a glass of wine every night with dinner. The flip side is there's other research that says no alcohol is better. So do you have a view on this as someone who's an expert in the field?
It's a difficult question to answer because for me, what I try to convey to people is if you're not active, you're not sleeping well, you have stress, you load up with processed foods, alcohol is not going to be a good idea to throw on top of that. Because we've got to reverse all these other pieces to it. Because people use it as a stress releaser.
Yeah.
And that's not a healthy way to look at it. I know what the FDA says. I know where some of the societies are saying, 2 glasses of wine may help the heart. I think you have to look at everything with the patient, what they're doing. And especially why are they doing it? And is it a stress component? I do say that though, and I have to emphasize is that remember that the heavy alcoholic that we see in liver disease, that's a person that's drinking 24 cans of beer a day. And we see those. You walk through an ER at any county and it's going to be loaded on a Friday and Saturday night with guys that have sarcopenia and bellies with ascites. Those are the heavy drinkers. That's only 1 in 5 of those folks get into liver trouble. 1 in 5 heavy drinkers get into, It's an amazingly smaller number of people, but we're seeing more of the reason we're seeing MASH as the leading cause for liver transplant now, I think is the chemicals. You throw in all the processed foods, all the chemical laden foods. What is it now? 90,000 chemicals that are used in developing our food in America today. And then you have somebody, I can drink 2 or 3 glasses of alcohol a day. On top of that, then not exercise, then keep your stress where you are, then not sleep. And then we ask, well, why did this happen?
Yeah.
Holy cow. Really? So I think the best thing is to limit it to occasions, celebrations, and not go crazy. But it's tough. We went on a cruise ship about a year ago, and half the boat has a body mass index over 35, and they're drinking all night. We're going the wrong way.
We're going the wrong way. Yeah, I agree. Well, yeah, we've talked about MASH, the gut, genetic testing, your clinic, your journey as an entrepreneur, even Hippocrates. So this has been a very engaging.
He was a big guy, you know.
He was a visionary.
He had it going.
Pure visionary. And I've learned a lot. I'm sure the listeners have too. And I wanted to extend my thanks to you for taking time out of your busy schedule to come on the podcast. And it's been a lot of fun talking to you.